and I would say comments and any disagreements. So anything that's not clear, it really is important from my point of view to have as much interaction as we can. And of course, if we were all in the room together, we could sort of have hands raised and so forth. So you have to chat in the question and answer, send it to all participants, and please feel free to question anything that comes up. If you don't quite know how this applies to you, we have about 50-50 treatment providers as well as court teams, and I recognize that as a clinician, I'm going to be talking about some of the clinical aspects, but the purpose of this is to really open up the conversation so that everybody can kind of know what to expect from treatment providers and vice versa. So we've had some good comments to say, how can we make this applicable also to the court team personnel? So would really encourage and invite anybody, but especially from the court side, if you have questions about how does this apply to you and what's your role, please raise that, and we'll try to answer that in real time. So Monica knows to interrupt me if something comes in and a question comes up, and we want to make sure we address everybody's needs.
And Dr. Mee-Lee, I'm just going to go ahead and interrupt you right now really quickly.
Yeah.
We do have a question in follow-up to yesterday's session. It might be helpful to address before we jump into this case.
Sure. Okay.
So Jeff Kushner says, as a follow-up to yesterday, what would you recommend for drug courts to do after a drug court participant graduates and they lose jurisdiction? New standards recommend at least a 90-day follow-up after graduation.
Yes, I think that by all means, and I would say more than 90 days, if the court team, along with the treatment provider, feels like, yes, the person made some good gains and they were able to have negative drug screens and they've sort of gone through the phases, but we really think they are not very embedded in recovery, and that we would recommend ongoing treatment. I mean, from a pure chronic disease model of addiction, very few people with addiction get cured after any period of treatment. So just because they may have improved function or been able to meet comply with court orders for certain amounts of attendance at 12-step meetings or mutual help groups or negative drug screening, doesn't mean that they are well on the road to recovery. So any way that a person could be continued in ongoing care would be, from my point of view, the ideal. And really, if we're going to get the outcomes we want, it would be surprising if somebody goes through drug court and then, you know, is sort of cured. So 90 days or even more, even if a person's doing well and is well engaged in you know, recovery groups and is sort of self-propelled in that, ongoing disease monitoring, I think, is important. One of the reasons physicians, health programs, and pilots and other professionals in safety-sensitive occupations get such good outcomes is because they are often required to be monitored for 5 years at least. And I would say, like any chronic disease, some level of monitoring can get the outcomes. I understand from a criminal justice point of view, we don't have the teeth in that, but anything that could be done to encourage that kind of ongoing disease management, I would love to have more people brainstorm about that with criminal justice. Incidentally, if you send in a comment or a question and don't want your name mentioned, that can certainly be done, because I'd rather have your question or comment or disagreement than to have you not ask a question or make a comment or a disagreement because you're frightened that your name will be announced. So, Monica, we can just check on that. In fact, you know, we don't need to mention people's names if they write it in unless they would like that to be done.
Of course. Yep.
All right, so let's get on with this case. This was a case that really came from a drug court clinical coordinator. So our first case came from the court team. This is from the clinical side. And I'm just put into the slides basically what the person sent, but I highlighted in yellow some things that I want to make comments about, hopefully as a learning opportunity for from the clinical point of view for sure, but also for the court team side to understand what goes into what you should be expecting from treatment providers to help you to understand the complexity of some cases and how that impacts on some of the requirements that are handed down from the judge or other court team members in terms of things that the participant has to comply with. Because this case, I think, illustrates where the expectations might have been too great for the clinical complexity of the person, and that has contributed to their not being able to proceed through all of the phases of the drug court. So the person who sent this in said that my colleague and I have been listening to these webinars, and it's helped to learn different ways to articulate cases to the drug court team. And so it's been useful in that way to identify what some of the individualized treatment needs are. And this particular client is being presented because they've been in drug court for 16 months already, and some others typically complete drug court in 12 months, and yet this participant has not yet been able to move even past phase 1. And as it stands now, with 3 phases and 4 levels of treatment, the client is in level 2. So you can see how this client, it's a woman who's not proceeding through and can't really get to graduation, which requires at least 120 days drug-free. So the questions that the person who sent this in raises were, where should my focus be with this client if she is to be successful in the drug court program? Can someone with psychosis, and this person has symptoms of psychosis and auditory and visual hallucinations, can someone with psychosis be successful in drug court? Is there such a thing as too much treatment? We'll go through in a second and you'll see what treatment she is getting. And when is that line crossed into too much treatment, if there is such a thing, and what might everybody be overlooking to get this person to the best outcome as possible? So we're talking about a 38-year-old Caucasian. The participant describes herself as white, female who's divorced. She's got 4 children, ages 21, 13, 9, and 5. She's unemployed and recently approved for Social Security income disability, and you know, has no intentions to work. Since we're talking about, followed up with the clinical coordinator sent this in and asked what was she recently approved for SSI? Was it a psychosis, mental health diagnosis, or a seizure disorder, or both, or something else? And the answer to that was it's not fully clear what she obtained disability for. It does not appear it was for the psychosis, because this was new to other team members. And after reviewing her chart and her interview accepted with the drug court, the client has a history of episodic psychosis, typically around when she is pregnant, but we're not really still clear on why she got SSI and whether it was for a psychotic illness that could well have been for a seizure disorder or post-traumatic stress disorder, which had been documented before. Now, the reason I had asked that question is that if somebody is on SSI and it was for a mental disorder, that would raise the question from the beginning in terms of, was this an appropriate person for a drug court participation in the first place. The client, the participant, currently resides at a violence protection women's shelter because she was getting into some abusive relationship with a male. In December of 2014, the client was referred to county drug court for a felony charge of witness tampering. And during her son's sentencing hearing, apparently, and this is some more information from the clinical coordinator, the judge gave the client a felony charge because she pointed at a witness and said some threatening words at her son's court hearing. But she does not have a history of violent or threatening behavior other than just that one day. So apparently she got into drug court because of this a violent outburst at her son's court hearing, and that raises again, some of you are more knowledgeable about this, but I had the impression that people had to have some sort of drug-related offense to get into drug court, or at least where people felt that the person's addiction, illness, was the cause of the person's offending behavior. And that, therefore, by getting addiction treatment, we would then reach goals of decreased legal recidivism and crime and increased public safety. So it's a little curious to me why she got into drug court in the first place, and maybe some of you have the answer to that. And if so, please feel free to comment on that. Her son remains incarcerated. The client lives in Georgia, but was raised in Georgia, but lives in New Hampshire, but wants to be in Vermont, and describes herself as a believer in God. She feels proud that her children were raised as Christians, but she currently does not attend church. She went to the 11th grade, but has got her GED. So you can see from very early on, she's been involved with pregnancies, and her problem with driving is that she's reported to have a seizure disorder. Now, the clinical coordinator has been working with this participant since December of 2015, involving 5 one-hour individual sessions and a facilitated intensive outpatient sessions, 4 3-hour intensive outpatient sessions. So you can see the client is getting a fair amount of treatment, and that was really one of the questions the questioner raises: is she getting too much treatment? The client has had 3 positive drug screens, one for codeine and morphine in October, in January, and then 2 for alcohol in December of last year and in January of this year. But she says she didn't use, and she is raising what we often hear. She had an everything bagel, which had, poppy seeds on it probably, and said that she was drinking from a universal pitcher of a jug at the shelter, and claims those were the causes of her positive drug screen. So fairly dubious, obviously. In January 2016, she was found to be pregnant. She had sleep studies from February in the 1st until the 5th, and it was decided that most likely her seizure activity was psychogenic in nature and not epileptic seizures. So it raises some question about what her seizures are, but we'll get some more information about that in a second. She decided to terminate the pregnancy in February of this year, and then ended up in an inpatient psychiatric unit in March because of suicidal ideation, and starting to drink alcohol, which she said was to save her from using heroin. So she understands, in further questioning of the coordinator that I sent, she understands she has mental health problems and addiction issues, but she finds herself drinking to try to stave off her more serious opioid use disorder. She discharged herself from the psychiatric hospital in March because she was frightened of losing her housing, but then she began having auditory and visual hallucinations, which then caused her to check herself back into the hospital later on in March, and then to leave at the end of March. Now, just FYI, usually when we hear about auditory hallucinations, we think about psychosis like schizophrenia. When you hear about visual hallucinations, you think more about organic and substance-induced reasons for hallucinations, or organic medical or physical health problems. Usually visual hallucinations are to do with more organic causes, auditory to do with more mental health psychosis. It's not universal, but so it's a little confusing there about why she was having hallucinations. And of course, just the report of hallucinations, we have to kind of check what that really means. So when people say hallucinations, you really want to dig a little more deeply and say, well, what do you mean by hallucinations, and see if they can describe them as actually hearing things that other people don't hear, and not just vivid thoughts in their head. Some people are vividly thinking, and they call those auditory hallucinations. It really is like if you were in a hospital and you hear your name called. That's what an auditory hallucination should be like. But if you're kind of obsessing about something and you have vivid sort of voices in your head, that might not be an auditory hallucination. Same with visual hallucinations. It should be that you're actually seeing things that other people don't see, and it shouldn't be just sort of vivid images in your mind. Since that date that she was discharged, she has drunk on 2 more occasions. Again, she says to medicate hallucinations, and also, you know, trying to make sure she doesn't go back to opioids like heroin. She's aware that she's extremely anxious and desperate, and you know, this has escalated when she's upset. So some background about this is that in February of 2015, she was first reported to as a seizure in drug court, which led to a head injury. And one of the questions that I raised was the head injury observed, and was she actually in a clinical setting or at home? Was this, you know, her report that she had a seizure? Was it perhaps a withdrawal seizure? Was she drinking, and it could have been part of withdrawal? Or was she intoxicated or recently using substances? And the questioner of this case said the client was living at a sober living facility at the time and was not under the influence or in withdrawal. So sounds like it was more clearly an actual seizure, especially since she sustained a head injury with loss of her ability to taste and smell. So that does sound more serious, and even affecting her reading and comprehension of written material after this head injury. So that complicates her ability to even participate in drug court as well, which can explain why she's having trouble getting through the phases. The client reports that she first started cocaine at 23, opioid use at 32, and has a history of amphetamine, gabapentin abuse. Gabapentin is a seizure disorder treatment, which sometimes you don't think of it as being addictive, but people use it because it does give some mood changes, and so it can be used for those purposes, even though it really is an anti-seizure medication. You can see she's on a variety of medications: buprenorphine for her opioid use disorder, sertraline, antidepressants, hydroxyzine, Seroquel. so antipsychotic medications, Topamax, seizure, and gabapentin seizure medication. And her diagnoses spread across a variety as well. Major depressive disorder with psychotic features, opioid use disorder, alcohol use disorder, tobacco use disorder, seizure disorder, hepatitis C, traumatic brain injury, and personality traits, and also PTSD, post-traumatic stress disorder, because she really has had a history of abuse in the past. She has had 2 of her youngest children taken away from her, presumably because of her addiction. And she, though, stays in contact with her son, who's incarcerated, blaming herself for his incarceration, and she has visited him in prison. So she says on occasion that she should be the one in prison, not him. So she has a number of guilt feelings about how she has raised her. Her oldest son is incarcerated, unable to make contact. She has partial custody of her second child. So I highlighted that because we're dealing with somebody who really has had a number of pregnancies, and though has suffered from children being taken away from her. She has gotten into drinking, and this has got her out into actually some unhelpful relationships as well. The sexual abuse, the physical abuse. She has had hallucinations, auditory and visual hallucinations during past pregnancies, starting in 2010. And when she got into recovery, she met a man who was also in recovery. They moved in pretty quickly together, and then he began sexually abusing her regularly to the point where she realized she had to leave the relationship, started residing with her ex-mother-in-law, and then this also led her, appropriately really, to some trauma counseling, because this is a person who's had problems with sexual, physical abuse. So she's been in trauma-informed therapy twice a week from July 2015 to March this year, and describes her therapist as her best friend, and actually has referred to other treatment providers prior to the drug court as friends and family. And I think from a clinical point of view, this is important because as the writer of this case said, that they are seeing each other for individual sessions, individual and group sessions, and the relationship between them a little later on hasn't been going so well, because the clinician of this case really sets more clear boundaries than perhaps other clinicians have done with her. So she's getting individual, attends 2-3 hour drug courts weekly. She's getting drug court expectations for 5 self-help meetings and 5 random UA screenings. So 5 random UA screenings is pretty intense. Some of the literature talks about a minimum of 2 random UA screenings is probably reasonable enough. 5 seems a strong obligation. Now, maybe that's because she hasn't been able to maintain much sobriety, but you're not going to get a lot more benefit from having 5 random UAs. The cost and the pressure and the time on the client doesn't really render much improvement to have 5 versus 2 random drug screens. And as you can see, she's getting a fair amount of treatment: trauma-informed peer support group, medication-assisted clinic counselor 1 to 2 times a week, And in looking at her gain assessment, this is an assessment that includes the ASAM Crtieria Dimensions. She has reported a lifetime history of being beaten, sexual abuse, emotional abuse. So good reasons to have a correct diagnosis of post-traumatic stress disorder and trauma-informed treatment. Now, the clinical coordinator who presented this case has a formulation that the client has obviously significant mental health and personality disorder symptoms that has been described as dependent. I would also raise whether there are borderline personality issues, and some of the reasons for raising borderline personality disorder is that borderline clients often have poor boundaries where they can often bond with a counselor and say the kinds of things this client has said, that, you know, my therapist is my best friend, and describes other therapists and counselors as family. And in this particular case, the clinician who presented this case feels that she has good, healthy boundaries, and that the client has said several times, I don't know if this is going to work out between us, because this lack of trust of the client may be related to the fact that there are stronger boundaries with this clinician than there have been with previous therapeutic relationships. And so why is borderline personality disorder issues important to raise? Well, you're going to have a person who, if they're involved with too many different therapists and counselors and having too many different treatment settings, that it opens up the possibility for splitting things and really not having a good continuity of care. And this speaks to the issue that the questioner of this case raised, is there such a thing as having too much treatment? And the concern is that the stressors of being in the drug court program seem for this client to have been detrimental, looking at the seizure activity and then the TCU client evaluation of self and treatment, where the scores apparently have not been good, and that have been demonstrating that the client is not doing well. So with the continued use, with the seizure activity, with the inability to maintain any abstinence, the clinician who sent in this case has tried to provide the drug court team and the judge information from the start of working with the client to see if then some alternative treatment might be better for this person, given her mental health status and this question of psychosis, inability to get significant abstinence, and whether there is too much treatment, too many expectations being placed on this client above their ability to actually do it, so that they never progress. Recently, this clinician was able to formulate a plan of reducing the amount of meetings and treatment groups a client is required to do. So that sounds good, that the discussion between treatment providers and the court team was able to get a better outcome for what the expectations are of drug court. And that, I think, speaks to the importance of really making sure we stay in good communication between everybody. And if the client doesn't seem to be improving, we can't just blame the client. We might want to look at, do we have the wrong treatment plan? The clinician has also verified with the case manager that the client would not lose her housing at the shelter if she did need to be in inpatient treatment for a longer period of time. You remember that the client checked herself out of the inpatient psychiatric unit for fear of losing her housing. So the client was just recently referred to inpatient treatment, and as I assume, an attempt to stabilize things. So coming back to the reasons for this challenging case, that the fact that she has been in drug court for 16 months and hasn't been able to move through phase 1 and has not been able to sustain long enough periods of abstinence. And the questions then, where should the focus with this client be if she's to be successful? And let's try to answer some of those questions. But before we do that, I tried to clarify further more information, and I've gone over some of this, but some of the information I haven't given you. So you remember, as regards why did she get SSI, we're not fully clear at this point, or at least the person who said in the case isn't clear. We'd have to get more information. The relevance of this, though, the learning principle in this, is if somebody from day one looks like they have significant mental health problems, and if they were on SSI for a physical health problem like seizures and for a mental health problem like PTSD, that would be an alert to say, is drug court the most appropriate court for the person to be in? And would it be better for them to be in mental health court, or in some counties and states they have behavioral health court, to address the fact that people with co-occurring disorders are going to need different kinds of expectations from the court, and that there's going to have to be much more careful coordination between the treatment team and the court team to make sure that expectations are realistic and that the person's getting truly individualized treatment. I had asked, were the client's auditory and visual hallucinations time-wise related to drinking or drugging, and did they occur during any periods of being abstinent? Because if somebody has auditory or visual hallucinations closely related to substance use, then that raises some question about whether this is really a co-occurring mental disorder or whether it may be just a substance-induced problem. And this goes to the question of then, are they appropriately in drug court, or would they need to be in some mental health court or behavioral health court? Now, in this person's case, the answer was it appears that her psychosis has been during significant periods of abstinence and self-reported to be around pregnancy. So this would point in the direction that perhaps she does indeed have co-occurring addiction and mental health problems. She clearly has addiction problems, which would make her appropriate for drug court. But the fact of these auditory and visual hallucinations and psychosis during periods of pregnancy makes the question raised, especially if she was on disability for PTSD, where the drug court alone is the appropriate place for her. Another question that I asked of the clinician is, do you know the longest time she's been abstinent, or better still, has she been in recovery and sobriety? Now, the reason for this question is that if you have a person who has had perhaps a year or two or even longer with good sobriety, perhaps being active in self-help, mutual help groups like AA, and you have that history, then you want to know what happened to the mental health signs and symptoms during that period of absence or sobriety. And if, for example, they had a good period of sobriety of a year or two and they didn't have any of these auditory or visual hallucinations and didn't have any psychotic symptoms, well, then that would point in the direction of it being more of an addiction problem. The answer to that question was that her longest period of sobriety was 16 months. Some of those months were witnessed by the drug court team, so that it sort of verified that she really had some sobriety. But according to a colleague who facilitated groups that the client was in, the client during that time when she was sober was actively engaged and even took a more of a leadership role in the groups, but her ability to participate in the group seemed to decline significantly after the seizure and when she got the head trauma. So I don't want to get too much into the weeds of the clinical aspects here, but if she had a period of sobriety for 16 months, and if during that time she was able to be actively engaged in the groups, that makes you wonder, you know, how serious and severe were her mental health signs and symptoms during that time. But clearly now at this point, with the head injury and with the seizure and with the history of PTSD and with the history of these auditory and visual hallucinations, I think it's safe to say that this person clearly has a co-occurring addiction and mental health problem. Another question I wanted to know was, does the client believe she has an addiction problem and a mental illness? In other words, what is her stage of change around both disorders? Because some people can recognize that they have a mental health problem but not an addiction problem, or think they have an addiction problem but not a mental health problem. In this particular case, further information we got was that the client is fully aware that she has mental health and addiction issues, and from the client's self-report, she recognizes that she has an opiate problem. The problem is that she's using alcohol to try to not use heroin, but she certainly recognizes she has PTSD and problems with opioids, cocaine, and amphetamine. So this is a person where we don't have to do much motivational work around her recognizing she has addiction and mental health, but we do have to do some work with a more complicated treatment plan given physical problems, cognitive difficulties, mental health signs and symptoms, and severe addiction for which she's being maintained on buprenorphine, or trade name Subutex. What were the circumstances of the February 2015 seizure? We already talked about that. It happened apparently in a situation where she was not intoxicated. And then I asked, is there a mental health court or a co-occurring disorders court that might be more appropriate for her? And the clinicians whose case this is says, when I spoke to the client about alternative sentencing program like a mental health court, according to the client, she had never been offered this option nor even heard of it. The clinician felt it could be more of a benefit to the client because such mental health courts are often less intense and more flexible in terms of individualized treatment, where the expectations may be less arduous and less demanding on a client who may not be able to actually do that. The clinician brought this idea up at a case presentation with the entire drug court team, and the state prosecutor argued that there is not enough supervision in alternative sentencing program like a mental health court, and did not feel comfortable making a bargain in transferring her to it. So the consensus was that they wanted the clinician to come up with an ideal treatment plan for the remaining part of her drug court stay. Now, that comes back to the questions then about is there such a thing as too much treatment, and where does that line get crossed? So if you remember, this client is getting trauma therapy. She's getting groups that are mandated from drug court. She's seeing the clinician in both individual and group work, and required to have 5 random urines a week and 5 self-help probably AA meetings or something as well, plus she's seeing a counselor at the maintenance program where she's getting the buprenorphine a couple of times. I would agree that I think that's too much for a person who has PTSD, active addiction, and that this is too high expectation of her trying to get benefit from that, especially since she has personality issues, which I think makes boundaries difficult, and that she's then expected to sort of form some sort of bonding relationship with the trauma therapist, the maintenance program clinician, this clinician's whose case this is as well. Where does the line get crossed? Well, I think what should be the guide to that is it working? Is the person getting better, or are they getting more stressed? And what is the client themselves saying about the treatment and their ability to do everything that's being required of them? Now, of course, you know, clients may complain that they want me to do too much stuff, and you don't just say, okay, well, we'll reduce it. But you have to take into account the diagnosis and look at all of the 6 dimensions. So if you think about these dimensions, on dimension 1, this client is still having problems with intoxication. She's drinking, as she says, as a way to try to cope with hallucinations and with heroin temptation. On dimension 2, she has traumatic brain injury, or at least some lasting effects from the head injury from the seizure. On dimension 3, she has a long history of sexual, physical, emotional abuse with PTSD, personality issues, psychosis, hallucinations during pregnancy. So there's significant problems on dimension 3. Dimension 4, even though she recognizes she has a problem, on dimension 5, she is actually demonstrating poor ability to cope with continued use. She's not been able to maintain significant abstinence and still continues to drink as a way to cope with mental health problems and as a way to cope, she says, with opioid use. So she has significant severity on dimension 5. And then dimension 6, she gets into this recent abusive relationship with somebody else who's going to self-help, mutual help groups, and she's in some shelter now, but and on top of that, she has child protective services problems. So on every dimension, this is a client who has significant severity. And while it's not the court team's scope of practice to know what to do, as they're in their right request to ask the clinician to come up with the ideal treatment plan, you can see from a discussion of this case, though, that a lot of coordination needs to go on between the court team and the treatment team. And I'm not clear, you know, the prosecuting attorney is saying there's not enough supervision in an alternative court, drug team, mental health court. But then my question would be, is there a real concern about reoffending, or what do they mean by supervision? So if we're talking about legal supervision, from at least the history, it doesn't look like her offense is the kind of thing. I mean, it's different if she were somebody with a substance-related multiple history of public intoxication, drug dealing, all kinds of impulsivity, that you want to make sure she has close enough legal supervision that she doesn't reoffend. That doesn't seem to be this person's legal history. She threatened a witness in her son's sentencing and was charged with witness tampering. What seems to be the need for much more close supervision is for mental health and addiction or co-occurring disorders supervision. And hopefully mental health courts or behavioral health courts or co-occurring disorder courts can do that kind of individualized treatment. So that would have to be a further discussion about what is the exact concern around the state prosecutor arguing for more supervision. So to go back to the questions that were raised, where should the focus be with this client if she's to be successful? Well, I think the focus needs to be on a mental health treatment plan and, of course, an addiction treatment plan. But the mental health plan should really be trying to make sure that the therapy is done as close to, in other words, that the therapy team that's doing the mental health, the trauma-informed therapy, that everybody who's doing mental health work be very close communication so that there isn't an opportunity for splitting. Not that the client is trying to be bad in splitting the team, but I suspect that her personality issues are going to set herself up for splitting the team, bonding to one person more than the other, what we sort of think of as black and white thinking, where one therapist is good and one therapist is bad. And so ideally, you want to try to consolidate the mental health therapy under one roof, where there is good communication if there's going to be more than one therapist involved, where there is you know, very close communication so that the client experiences this as one team and not as several therapists and several groups. So there needs to be good communication, and ideally probably one therapist who is working with the client and not three or something like that. So the focus should be on stabilizing her mental health and then, of course, stabilizing her addiction issues and trying to assess why is this person, and this is where individualized treatment comes in, if we're not getting a good progress and outcome with her not being able to maintain abstinence, to go back through the 6 dimensions and see which dimension or dimensions are most unstable and what do we have to do. So where should you focus? I think you need to reassess what the level of severity is in each of the 6 dimensions and reform the treatment plan to address those highest priorities, and then look at what's the level of care where this can best be presented. So to sort of jump ahead, it's really this process of what does the client want, what are they more focused on, are there any issues of imminent danger, and then go back through the 6 dimensions to really configure the treatment plan, and then look at, is she in the best treatment level to do that? Now, she's being admitted to an inpatient psychiatric unit, but that's not going to necessarily be the place to be in an ongoing way. That would just be to stabilize some things and not, you know, to make sure that we get a better sense about these hallucinations and psychosis. But really, the focus should be on ongoing outpatient work, if possible, and only think about residential sorts of settings if it's clear she can't maintain any stability. But if she's in a supportive living environment now and has the opportunity for intensive outpatient, I would keep doing that, but then also look at making sure we individualize that, perhaps decrease some of the court expectations to fewer than 5 random drug screens and fewer than 5 groups, and to look at what happens then to the level of stress and the deterioration that she was apparently demonstrating. What might we be overlooking? Well, I think we might be overlooking the fact that she needs to be perhaps in a different drug court or a different court where she can, where it's set up more to deal with people with more severe co-occurring issues. But again, I'm not sure. We'd need to hear more about what some of the concerns are from the prosecuting attorney and the concerns about supervision, about why that is not being considered. Now, I would love to have some members of the court team, or if anybody has questions about this or disagrees with anything we've talked about, this is much more useful to everybody if we have a dialogue, especially if you don't know about this exact case but have similar situations that you have faced. And let's try to have some dialogue about how we can help you think through this case in particular or similar situations that you come up against. Looks like we don't have any comments at this point. Just while we're waiting for some comments, I hope we get a reminder that we have 2 more sessions in this series, one on Wednesday, April 27 from 11 to 12:30 Eastern Time, and it's going to be on how do we get there from here, because we've talked about a number of different shifts in our thinking and policies and procedures over the course of this webinar series, and we want to look at how do we make changes and what would be a way to do that so that all stakeholders are comfortable, that we're moving together and that we are being still safe, but also making sure that we don't just perpetuate doing things because that's the way we've done it. And then on Tuesday, May 3, from 2 to 3 Eastern, we'll have the last of our challenging cases. And as of this moment, we don't have one. So this would be really important for anybody who has a challenging case, or if you have a series of vignettes of things that come up, even if it's not just one full case, but you say these are the situations we confront from time to time. We're not sure how to deal with that. Don't feel you have to have one comprehensive case. Any series of different dilemmas that one or more court teams or clinicians run up against, that would be fine too. So we don't have to have just one comprehensive case. Now, if the person who sent in this case is on the line, I'd love to have them come back at me if their questions weren't answered, or if anybody else have any thoughts about how this person could be improved.
Dr. Mee-Lee, it's Monica.
The outcomes. Yes, Monica.
So I did get a question, and it is, would it be possible for you to go through the ASAM Dimensions and guide everyone briefly through what risk score you would give for each?
Okay, great.
As it relates to this case.
So the assessment dimensions, I assume you're talking about, right? Because when because I mean, in the larger picture, the criteria itself has different combinations of severity in these 6 dimensions for different levels of care. So on dimension 1, we're looking at acute intoxication and withdrawal. So that if you had somebody who hadn't used for 30 days, for example, and they weren't now using at all, they would be a 0. If in the ASAM criteria, we often talk about 0 through to 4, or just for quickness of here, low, medium, or high severity, they would be low severity or 0 on dimension 1 if they hadn't used for 30 days, because they wouldn't be intoxicated and they wouldn't be in any danger of withdrawal. On the other hand, if somebody was being examined and they were now acutely intoxicated, they had slurred speech, they couldn't, walk a straight line, that would be acute intoxication. And if they said, give me my keys of the car, that would be a high severity of intoxication, a 4, and you would want to make sure that you watch them before they, did anything dangerous, like walking in front of a truck or driving drunk. On dimension 1, if somebody has a history of going into severe withdrawal whenever they go off their drugs, and they may have had seizures even, and now they have just stopped using, drinking and drugging at a quantity that if they were to go into withdrawal, it would be severe, that would be like a 4 severity. So somebody may have just stopped drinking a case of beer that they've been doing every day for the last 6 months. They're sitting there shaking like a leaf. They're about to, you think, have a seizure. That would be a 4. If they were in withdrawal, but it was mild, it might be a 1 or a 2. In the actual ASAM criteria book, there are sort of much more significant descriptions of what 0 to 4 would be. But we're looking at the severity of the withdrawal syndrome, which would then speak to needing to be in one of the 5 levels of withdrawal management. On dimension 2, if somebody had hypertension and diabetes, but it was very stable, so they were just sort of maintaining their level, that might be more of a 1 on a scale of 0 to 4. If somebody had no physical health problems at all, they were healthy, it could be 0. If, on the other hand, they are having active seizures and it's not stabilized well, that could be a 3. If somebody was having severe chest pain, looking like they were having a heart attack, or they were having problems breathing and asthma, they could hardly catch their breath, that might be life-threatening and be a 4 and then get stabilized. If it's more stable chronic condition, it would be more of a 1. If somebody's unstable but not to the point of life-threatening, it might be more of a 2. We're just giving a flavor of the range. On dimension 3, if somebody were actively psychotic or suicidal or was feeling hopeless and you felt they might do something impulsive, that would be more like a 4 on dimension 3. On the other hand, if they have chronic depression, they're not now suicidal or having any impulsive activity, it might be more of a 1. If they were totally healthy, mental health-wise, it would be 0. If somebody were relatively stable but still having some flare-ups of anxiety and panic, it might be more of a 2. So in this case, this client might be much more of a 2, or when she starts hallucinating, a 3. But if she were getting suicidal, it would, and actively suicidal, might be 4. So in this case, on dimension 1, she might be a 1 or a 2. She's still actively using, but not at the point of having a real withdrawal seizure. On dimension 2, she may well be a 2 because she's having the seizures, but it's not every day. It's not life-threatening, but there's enough going on that we have to monitor. On dimension 3, she may well be a 2 on a scale of 0 to 4. It's not just quiet and stable, but it's not actively life-threatening. On dimension 4, readiness to change, you might say she was a 1, meaning that a 4 is somebody who's saying, I don't have a problem, get out of my face, I'm not going to talk to you. But whereas on a 1, she's saying she has a problem, but she's still on dimension 5, it might be much more of a 3, because even though she recognizes she has a problem on dimension 4, she's not able to not use on dimension 5. So somebody can be motivated to want to be in recovery, but on dimension 5 not have the skills to do it. And that would be true for this client. And she also has mental health issues that can flare up on dimension 5. And then dimension 6, I would say she was at least a 2 in a recovery environment, in that she's needing to be in a supportive living, but she doesn't have a lot of supportive relationships, and she's got legal difficulties, she's got child protective services difficulties. She's not a 4 where she's homeless and in immediate jeopardy of freezing to death or being beaten up by somebody, and it's not a 0 or 1 where she has a very supportive living environment. So I hope that gives you a flavor for how to think through the dimensions and apply it to this case. But there are some e-training modules that you can see and get more information on, and actually go through those at asamcriteria.org. And you'll see on the left there a training module on multidimensional assessment that would go in much more in depth with that. And then from assessment to service plan to level of care, that would really walk you through going from that assessment to treatment planning to level of care. So those are some resources for ongoing training. Looks like we're at the end of our time. Monica, were there any other comments or questions?
There were no other comments or questions, just a few thank yous. All right.
So again, a reminder, our next session, if you care to join us, is on Wednesday, April 27, 11 to 12:30 Eastern Time. How do we get there from here? How do we make these changes? And then the final challenging case on Tuesday, May 3, 2 to 3 Eastern Time. And please send in vignettes or a case, we want to make sure that we address the concerns that you have. All right, thank you very much for joining us, and we hope to see you at the next one. And in the meantime, if you have any questions or other comments, feel free to send them in, and we'll respond to you offline.
Great. Thank you, Dr. Mee-Lee. Thank you, everyone.
Bye-bye.